Well, it's good to be with you all today. I wanted to go over the fee schedule and the fee schedule comment letter that AOPT has just submitted, as well as the broader issue of why it's critical that AOPT members engage on the fee schedule. Can't just leave it up to the folks in DC. We need members to be writing in and commenting. And what I love is that APTA makes that incredibly easy. It's trackable. We can tell what's happening. But okay, the top line of the fee schedule, right? Cuts. We are so sick of the cuts that Medicare imposes on physical therapists. It is unsustainable. It is something that radiates out then into private pay because your contracts are often based on Medicare rates. And it makes it impossible. It's more and more impossible, I should say, to run a practice profitably. To be able to be there for your patients is the bottom line. So we are of the opinion that the fee schedule process is itself broken. That Medicare payment fundamentally is broken. And so what folks are talking about in DC as a result of comment letters like this, as a result of what CMS is forced into doing by Congress, is a new payment system beyond what we have right now, or the current value-based payment models, which again don't work for physical therapy generally. So many physical therapists tried MIPS and found so many problems with it. It was just unworkable. Even the MVP, the sort of next step for MIPS, has very few measures that physical therapists can use. The cost measure, the only measure that's out there that we could use for cost on low back pain is highly problematic, right? So we've got to see some real changes. And what I love is that APTA and others are lobbying effectively. There are discussions going on in the Senate Finance Committee, as well as the Senate generally, about what to do about this. I'm not sure we're going to see any significant change within this Congress, but we very well could see some. So stay tuned. But I do fundamentally want to flag for folks that more cuts are coming. This is on a normal track record. What our hope is at this point is, now that the comment schedule, our comment time has ended, and we're sort of waiting. We're in this limbo or holding pattern for Congress, for CMS to produce the final rule, right? The one that we just commented on was the proposed rule. They make their proposals, we comment, and then they produce the final rule. The way it has often worked year upon year is that as they're getting that final rule done, and then it gets published, Congress says, oops, sorry, we actually want to give you more money and make those cuts a little less bad. So that's our job. Now that the federal government has received AOPT's comment letter, and hopefully many AOPT members' comments, now it's time to go to Congress and say, this was so bad, we need to make sure that these cuts are hopefully eliminated, but certainly blunted for the 2025 calendar year. So lots of work left to do. This time, the effort shifts to Congress and trying to get them to agree on something, which is always interesting with Congress, to make Medicare payment more reasonable. Now, again, cuts, very, very important, but they are not the entirety of the fee schedule. There are a lot of policies that are embedded in the fee schedule that impact Medicare, but they can also impact private pay, Medicaid, CHIP, other plans, ERISA plans even sometimes. Follow what Medicare does. It's generally considered the standard, and so that's why so many folks advocate on the Medicare fee schedule, not just the cuts, but also the policies. And I would just say, this time around with the proposed rule, APTA and other physical therapy advocates, we've had a lot of successes in the policy realm. So that means that we have had a reconsideration by Medicare, by CMS, the Medicare agency, on PTA supervision. Right? We've shifted around from general to other types of supervision. We won here, and the issue is that we are going to need to continue to keep this policy from the proposed rule in the final rule. So that's why commenting is always really important in August. I really hope that PTs will be able to put on their schedule before they take an August vacation, or maybe after they come back, certainly before the end of the comment deadline, that they do weigh in on, hey, I really like this policy. CMS gets a little tired of getting beaten up all the time, especially about things they can't control, like how much they pay. But they do really appreciate, who doesn't like receiving praise? So I think of some, bureaucrat with a green eye shade somewhere in the bowels of the CMS building and HHS, trying to pour through all these comments and come up with something that feels like their job matters. And I just feel like they don't get enough praise. It can be very helpful if we say this is going to help patients. What you've decided to do here will have a big impact on the Medicare population, and by the way, on the rest of the population that I care for. So important to give some feedback that's positive in any of these comments. There are some new CPT codes that we're going to be able to use. Caregiver training CPT codes 97550, 97551. And 97552. With the Medicare telehealth list, they went to provisional status. We want CMS to clarify in the final rule that the codes are classified as sometimes therapy CPT codes that can be utilized by physical therapists. And I hate to list more codes, but it's GCTD1, Caregiver Training and Direct Care Strategies and Techniques, GCTD2, similar, and then GCTD3. We want physical therapists to be able to use those codes for caregivers that they can then educate about how to provide services and support not really services, but support to Medicare beneficiaries. That's going to be able to amplify the work that PTs do in the rest of the community, and very, very important for you to get paid for that work too. One other thing that we're just really, really excited about, and I think it's critical we encourage CMS to keep in the final rule, is this real policy shift that people have been working on for a very long time. And again, APTA deserves just so much credit for getting this done, is the certification of therapy plans of care, right? There was just this huge mismatch between, somebody was referred over to a PT from a primary care doctor or another prescribing nurse practitioner, others, and then the PT would come up with a plan of care, and then the rules required them to send it back to the original prescriber and then get a signature on it before they could get paid, right? Certainly, many PTs were already providing services. They took it on themselves to, have the risk of not being paid. And, physicians that I've spoken with, I used to work for the family physicians and the pediatricians, the American Academy of Pediatrics and the American Academy of Family Physicians. They would often not even know that this was an issue for PTs, which is kind of mind-boggling. But the other thing that I was constantly told was that primary care docs are swimming and drowning in the amount of work, paperwork, coding. All that stuff is just, it's really hard at the primary care level to keep everything straight. So by eliminating the signed plan of care before you can continue services, I just think it's a really important innovation that we want to keep really, really badly. We really want to keep it in the final rule. So very important to weigh in, praise CMS for that shift. And I think it's really going to make sort of gaps in access for patients really be eliminated. Now, in our comments, we encourage CMS to actually just guarantee that PTs are going to get paid, even if the signed plan of care comes back a little later. That seems to be appropriate because if it's sort of approval by assent, as opposed to having to be in a holding pattern for that primary care doc or nurse practitioner or whomever to sign off on something that do physicians really change plans of care very often? I mean, I just think it's really, really rare. Maybe it just really unusual for a plan of care to be shifted by a physician after the PT gives it to them. So I just think it's a useless hurdle for PTs to have to jump over, and for physicians to unwittingly make PT lives harder. And so we're just really pleased that CMS was willing to shift that rule. We've got to keep it in the final rule, so it's important that we keep going. And we've asked CMS to clarify some things. I'm not going to go too deeply into misvalued codes. There was an earlier discussion of this in one of the earlier videos. We're hopeful that they actually will increase the valuation of those codes, different than what the RUC suggested. HICPAC, which is the sort of subgroup of the RUC that looks at non-physician codes. They applied the MPPR, which is just inappropriate. We believe that's already being addressed within the codes. And so it's important for us to continue to try to push CMS to have recognition of what they said in the 2024 physician fee schedule, that these misvalued codes should actually be valued more highly. So if those valuations that we're suggesting do get increased, or go to the level that we've suggested and that CMS seemed to have endorsed in 2024, there will be more money on the table for PTs to be able to care for their patients. And that's a way around at least some of the impacts of the overall Medicare cut. If you increase the RVUs associated with codes, those RVUs will then be radiated or amplified, multiplied by the conversion factor, and then you get paid more. That's the way that the system works. Diagnostic services got added. Some value-based payment niceties got tightened up. What I would say is that AOPT, the main stuff that we did in the comment was the cuts. That was a big focus of the comment letter that AOPT filed. And then additionally, how value-based care works, because there's just such clinical and measurement expertise within AOPT. You guys have the clinical practice guidelines, right? You guys are really the ones who know what the evidence shows for PTs in the orthopedic realm. And so it's really important for AOPT to weigh in and say, well, this code will work and this code won't. Why don't you include promise measures? CMS seems to refuse to recognize that promise measures are a great way for us to show overall patient improvement and care life. And then additionally, MIPS is just, there's not enough money on the table. So many people have tried the MIPS program, and the juice has never been worth the squeeze, and from any PT practice that I've heard. Right? They just they put all this money into the infrastructure of it, and then the payoff is much too minuscule to justify that. So there's got to be some changes here. It's one of the big thrusts that we have on trying to reform the entirety of the Medicare payment system. So I think there's good news, strikingly, in the fee schedule. And again, where we are right now is we filed our comment. Hopefully a lot of AOPT members filed their individual comments. APTA, of course, filed theirs, and under the auspices of the payment consortium, APTA private practice also filed theirs. So, we are getting the word in to CMS about physical therapy and what's necessary. Again, the focus of the AOPT comments were on payment cuts and quality metrics and making sure that value-based care makes sense. And right now it doesn't, with many of the models that are being produced by CMS and implemented. And so we're very hopeful that they pay attention to us this time, that we succeed on some of the things that we've said about how value-based models should change, and then how Medicare payment reform should occur. I will also say that this is a good example of the interaction between what Congress does and what the regulatory agencies do. So CMS, of course, is funded by and overseen by the Congress, right? There is an executive branch. CMS is within HHS, the Health and Human Services Department. It's a subgroup. I think there's 11 agencies under HHS. But, there's oversight, obviously. Congress gets to control, hauling folks in to talk about what they're doing at the agency level. And then fundamentally, they get to control both payment streams to the administrators of CMS, as well as the payment formulas, or at least the dollars that are on the table for CMS to spend. So Congress at this point is where we train our fire. And, it is really important to sort of lock in the good stuff and try to push back on the bad. What I would also say is, just if you look at this last year and a half of the advocacy that's been going on with Congress, a lot of the policy changes that CMS felt comfortable in implementing were really driven not only by advocacy with the agency, but by the existence of bills that more and more more and more representatives, senators were willing to sign on to push CMS, let CMS know that there is a groundswell of support for things like the signed plan of care change, for the PTA supervision change. There were bills that APTA and APTA private practice, AOPT, were supportive of that got more and more co-sponsorship. And that led to CMS, sort of being able to wipe away from some of the sweat from their brow, saying, "Oh, if we make these changes on our own, we're not going to get raked over the coals by Congress." So, and by the way, it seems like there's a lot of popular support for these proposals. So that sort of dance between the way that Congress thinks and the way that CMS implements is really important to recognize, and why it's so critical that more AOPT members get involved in advocacy. We can help with that. And what I'm very excited about is the advocacy that's been going on. I'm really hopeful that come 2025, we know the cuts are happening. Hopefully they decrease a little bit due to our congressional advocacy. But that signed plan of care thing, I really hope it impacts practices, right? What a waste, and what a dumb policy for you to have to sit around while the patient gets worse, waiting on a signature, right? If that goes away, that should be a real improvement in administrative burden. It should provide some certainty for PTs that they're going to get paid for the services they do. And fundamentally, these Medicare beneficiaries are going to get the services they need, right? That's the whole point of the program, is to help get people get healthier. So again, I think it's critical for PTs to internalize the value they provide, to get engaged in advocacy, and to be able to tell the story of what that new policy is going to do, right? Coming back, because advocacy never ends, we'll have to go back and say, well, this worked really well, and we need to tinker with it here, or MIPS is a disaster. We need to do X, Y, and Z in response. All of those decisions are being made in DC and Baltimore with CMS, but it's really, really important to get the word out, let folks know on Capitol Hill and in with the administration and the agencies what the PT perspective is. And again, it's just so critical that AOPT members engage in advocacy. And so I've mainly spoken about the Medicare side, and really what's happening with the federal government there. But of course, there's other major policy shifts that are going on. One of which is this new United Healthcare requirement for inpatient Medicare Advantage patients. In network Medicare Advantage patients, to receive prior authorization for the services that they provide. We are pushing back against this hard. I will just say we're talking to the press. We're talking to folks within UHC. We're talking to Congress. We're talking to the agencies. I am really still shocked that UHC decided to do this, and also with a month's notice. And I don't think they were thinking about what it means for PTs, right? I mean, why would you stay in network if when you're out of network you don't have to do a PA, right? Like they're trying to. It's just a policy that makes no sense to me. The obvious thing for PTs to do is to leave the network, and I'm not advocating for that, but it is just this really. I don't think they were thinking about the implications of this. They saw somewhere that they're, I don't really even know what the motivations were behind this, except to throw in some more, to decrease how much they spend on care, right? That's fundamentally what this comes down to, is they're paying for less care because there's going to be PAs that get ignored. There's at least one PT practice I know of that, they requested 12 visits for a guy who just had a stroke. They received 4, right? And they spent, I think, 180 minutes on the phone for a PA requesting that. So I dare say diabolical in the way that impacts both PTs and patients. And so it's our job to push back on it. It's our job to give you the resources that you need to succeed at that. And that's what we're here for. So we're working on it. I wish we had more results for you, but we are continuing this advocacy fight. APTA is as well. And we're very appreciative of their leadership in this area. But it's really what the payment consortium and your membership dollar is trying to make practice work a little bit better. And then, hopefully, deal with some of these cuts and get more money on the table for y'all to be able to care for your patients most effectively. So that's what we're all about. We're here to help you, and we really do want to help you engage in this way. It's a lot easier than most people think. Hopefully what you can start with is look at your contract, trying to negotiate your contract based on whatever data you're able to produce. And then appealing denials. That's another great strategy that very few people use that gets the attention of the payers. So for more great strategies like that, take a look at the State Payer Advocacy Resource Center. We've got over 60 resources for folks on how to do better contracting, what appeals and external reviews look like, how to push back on the MPPR. There's just a lot that's there. And so we're hopeful that folks are utilizing that and contact us to help in their advocacy. So thanks so much for listening.